Hydrocephalus, hydrocephalus. Let's go. Hello and welcome to MK's Medical Review Series. My name is Dr. Moses Kazevu. This is a series on my YouTube channel where we'll look at medical topics in depth. Today we're going to be looking at hydrocephalus or hydrocephalus, depending on however you want to pronounce it. If you haven't yet subscribed to the channel, please subscribe to the channel, hit the bell notification icon to be receiving notification of such amazing content every time I post. Tell a friend to tell a friend we are doing topics on the video, rather topics on the channel, what am I saying? And drop a comment as well as drop a like to Zambia and beyond. Let's go. Here's our warm-up question. This is from OSCE Stations. A child presented as shown in the picture and a brain CT scan of the patient being followed up at Levi General Hospital. What are the abnormalities shown in the CT scan? What is the most likely diagnosis? Classify the classifications given and give one pathology in each. What are the clinical features of this condition? So here are the images, and you can pause the video at this moment, write down your answers. I will give you the answers at the end of the lecture. So let's talk about CSF formation. Let's talk about CSF flow. Remember that pretty much CSF is going to be absorbed by the arachnoid villi. These are granulations into the venous channels and the sinuses, and you have about 20 mils of CSF that is going to be secreted in an hour, and its turnover is about 3 to 4 times in a day. Remember that the brain is surrounded by meninges, the dura mater, which is adherent to the bone, the arachnoid mater, which is just underneath, and the pia mater, which is adherent to the brain parenchyma. Between the bone and the dura mater, you have the epidural space. Between the dura mater and the arachnoid mater, you have the subdural space, and beneath the arachnoid mater and between the arachnoid mater and the pia mater, you have the subarachnoid space. This subarachnoid space is where the CSF is going to be flowing. Remember that the CSF is going to be secreted by what is referred to as the choroid plexus, which are found within the ventricles. A large amount of this is actually going to be formed in what is known as the lateral ventricle. I will show you a picture in the next slide. Then the majority of this CSF that is going to be formed in this lateral ventricle is pretty much going to be entering into the third ventricle via an opening which is referred to as the foramen of Monro. Remember also that the CSF that's going to be moving from this third ventricle passes to the fourth ventricle via the cerebral aqueduct or the aqueduct of Sylvius. Then once the CSF is in the fourth ventricle, pretty much the CSF is going to be flowing now into the cistern magna through the foramen of Magendie, it's a central opening, and the cistern lateralis, which is through the foramen of Luschka, which is a lateral opening. Now from the cistern magna and the cistern lateralis, the CSF is pretty much going to be flowing through the subarachnoid space over the spinal cord, over the cerebral hemispheres, and it also flows into the central canal of the spinal cord. When you talk about the word hydrocephalus, this is simply an increased CSF under pressure within the ventricles of the brain. It can arise because of predominantly a few mechanisms. So one, it could be that this flow that I've just explained could be blocked in a way such that the CSF now begins to accumulate and pressure begins to increase in the subarachnoid space. Or it can be due to a decrease in absorption, where something is blocking the absorptive capacity and you're not absorbing enough. Or rarely it can be as a result of increase in CSF production. This is attributed mostly to the tumors. So here's a schematic to help you remember. So the formation of CSF fluid in the lateral ventricle passes through the foramen of Monro to the third ventricle, then from the third ventricle to the fourth ventricle via the aqueduct of Sylvius, then of course through to the foramen of Magendie and foramen of Luschka into the cistern magna as well as the cistern lateralis, which are pretty much into the central canal as well as the subarachnoid spaces over the spinal cord and over the cerebral hemispheres. That's pretty much how CSF is going to be flowing. Here's another pictorial diagram here labeled with the dura mater over there, you have the arachnoid mater over there, the subarachnoid space, and this of course is the brain and the spinal cord. And then here you have your lateral ventricles, okay, and the choroid plexus that's found inside the lateral ventricles. Here you have your third ventricle, and then remember that the aqueduct of Sylvius is pretty much leading to the fourth ventricle, which is pretty much in at the level of the cerebellum. Then you have the foramen of Luschka as well as the foramen of Magendie, which are pretty much these draining channels getting into the cisterns. So I hope you have a good understanding of CSF formation as well as CSF flow. Now, what are the types of hydrocephalus? So pretty much we can group them into non-communicating, or referred to as obstructive, versus communicating, which is referred to as non-obstructive. Now, you may also have other types of hydrocephalus, which is known as normal pressure hydrocephalus, as well as hydrocephalus ex vacuo. This is pretty much happening where you have enlargement of the ventricular system, but it's a compensatory response to atrophy that's happening in the cortex. This is actually not even a true form of hydrocephalus. The two that I want you to focus on are the non-communicating and the communicating types of hydrocephalus, or the obstructive versus the non-obstructive. So in the obstructive, you have enlargement of the ventricles because there's an obstruction to the flow of CSF in the ventricular system. Remember that the blockage can actually happen at any level. It can happen at the ventricular system, commonly happening at the aqueduct. Sometimes it can happen at the foramen of Luschka, even the foramen of Magendie. You may sometimes commonly have the stenosis of the aqueduct of Sylvius. And remember, whenever a tube is blocked, everything that is behind it will begin to accumulate. So the CSF will accumulate in that ventricle behind this blockage. You may also have a periventricular ooze that's seen on the CT scan or the MRI, and this can actually help in identifying obstructive hydrocephalus. Then with communicating hydrocephalus, you have pretty much enlargement of the ventricles as a result of pretty much increased production of CSF. So with the tumors, you could have a tumor that's a papilloma of the choroid plexus, or predominantly even a decrease in absorption of CSF, for example, in patients that have bacterial meningitis. Causes can be divided as congenital versus acquired. So the congenital causes can be classified as intrauterine infections or infectious causes, toxoplasmosis, cytomegalovirus, as well as rubella. You can have intraventricular as well as intracranial bleeding. This is even much more common with the preterm infants. You may have congenital malformations. I want you to know of these three malformations, predominantly congenital aqueduct stenosis. Remember that this is stenosis of the aqueduct, and it's going to be an inherited disorder. It's an X-linked trait, and these patients have thumb abnormalities, and they may also have other CNS abnormalities such as a spina bifida, which is why if you get a patient that has hydrocephalus, it's always important to examine the spine in the neurological examination. Then you may have a Dandy-Walker malformation where you have either an absent or hypoplastic cerebellar vermis and a cystic enlargement of the fourth ventricle. This is obviously going to be blocking the flow of CSF. And remember that this posterior fossa cyst is usually continuous with the fourth ventricle. You may also have an Arnold-Chiari type 2 malformation, where there is a downwards displacement of the cerebellum and the medulla through the foramen magnum into the cervical spine. So this is going to be blocking the flow of CSF to the posterior fossa. Now, this malalignment or malformation is associated with the lumbosacrum myelomeningocele, which is why I keep emphasizing that it is important to examine the spine. You may also have some midline tumors obstructing the CSF flow. This is supposed to be a point on its own and not really under congenital malformations. Acquired causes include infections like TB meningitis, chronic meningitis, and even pyogenic bacterial meningitis. You may have post-intraventricular hemorrhage, posterior fossa tumors like a medulloblastoma, an astrocytoma, and an ependymoma. Remember that the bulk majority of the cancers that we see, or the tumors that we see in children, are pretty much gliomas in the terms of the CNS, because the glial tissues are the ones that are actively dividing in the CNS. Then you may have atriovenous malformations like intracranial hemorrhage. Most patients are usually preterm, as I already alluded to earlier on, or it could be a rupture of the aneurysm in the brain. Now, what's the pathology that's seen in hydrocephalus? You have ventricles that are being dilated, and sometimes this dilatation can happen unevenly, where you have one ventricle being dilated to a significant effect as compared to the other ventricle. The ependymal lining of the ventricle is going to be disrupted, and this is going to be resulting in periventricular ooze. So you have this periventricular white matter which is compressed. then the cortex is generally going to be preserved until later on in the disease, where you may have cortical atrophy. Then this process becomes this process is largely reversible if it's treated earlier, but then it may become irreversible in the late stages, and the child may actually have significant central nervous system complications. Now, what's the history of this condition? So you want to ask if the child had any fever before the head started getting big. This could be in relation to meningitis and all those infectious causes. Is there any history of convulsions? What was the baby's head circumference at birth, and was the baby born at term or preterm? Did the child cry immediately after birth? At what age did the caregiver notice the head getting big? Any abnormalities of the spine that were noted? Any similar illness in the siblings? And what treatment was given, and for how long this treatment was given to this infant up to this point? Now, what are the clinical features? The most significant thing that you'll be able to notice firsthand is pretty much the increase in head circumference. So here, if it crosses percentile lines, the major percentile lines, or the head circumference is greater than 97% for that age, then we do consider this as hydrocephalus. I talked about head circumference and other anthropometric measures in the video on pediatric growth and development assessment. So if you haven't watched that, head over there to the playlist. We'll leave it linked at the end. Then the infant is also going to be having open cranial sutures. So when you'll be able to palpate the sutures, they'll be split. You may have a large anterior and posterior fontanelle, and the sutures are going to be split. You may have what is referred to as a sunset sign. I will show you what this looks like in the image in the next slide. So here the sclera above the cornea becomes visible, and this is only because you have this increase in the pressure in the CNS, and this third ventricle is enlarged, and this third ventricle can sometimes compress on the upward gazing centers which you find in the midbrain. So once it compresses on the upward gaze centers in the midbrain, it means that both eyes are going to be now deviated downwards, like as if the sun is setting. Then you may have an abnormal skull contour, a prominent forehead, scalp veins which become prominent and dilated, and a crackpot sound on percussion. Other children that have closed sutures and they have increased intracranial pressure may have features of headaches, nausea, projectile vomiting, personality and behavioral disturbances such as irritability. They actually do cry inconsolably in the children. Then they may have head banging, apathy, drowsiness. They may sometimes have a unilateral sixth nerve palsy where they have a convergent strabismus or esotropia where one or both eyes is turned inwards. And then this is, of course, the primary symptom, which is going to be diplopia. They will have double vision. They may have papilloedema, they may have brisk deep tendon reflexes, but this is sometimes with usually downward plantar response. The limbs may become spastic because of stretching of the cortical fibers. There may be distortion of the brainstem that may lead to some symptoms like bradycardia, systemic hypertension, and an altered respiratory rate, the so-called Cushing's triad. Congenital hydrocephalus starts in the fetal life and actually may manifest or develop subsequently. The large head actually at birth may cause difficulty in delivery. It may cause some trauma during delivery to the mother as well as even to the child. And there may also be other associated congenital malformations. Now here's a picture. As you can see, this child's eyes here appear like as if they're about to set. So this is what we refer to as a sunset eyes. We can see the prominent forehead, the large head. Same thing that's happening here. I think this baby's cute. So how do we evaluate? So there will be an increase in head circumference and signs and symptoms of increased intracranial pressure. These mandate that you should get an urgent CT scan. So you should get serial measurements of the head circumference, essentially for an early diagnosis of hydrocephalus, and this should be reported with a serial ultrasounds of the head. So an increase in the head circumference in the first 3 months that is greater than 1 centimeters every 2 weeks, this should be the suspicion that this child could have hydrocephalus. So the brain grows very rapidly in the first week of life, and thereafter the sagittal sutures and the coronal sutures may actually be separated by up to 0.5 centimeters. So this physiological separation is meant to disappear after the first 2 weeks. So persistent widening of the squammal parietal sutures is not physiological, and once you see this, you should suspect that there is some hydrocephalus. Then the CT scan will give you information about the cortical mantle, if there's any presence of periventricular ooze, and even sometimes the etiology of hydrocephalus. An MRI can also be done to determine the site of obstruction, and in congenital hydrocephalus, it's also done to pick out certain malformations like Arnold-Chiari malformations, where there's downward displacement of the cerebellum, the medulla, as well as obstruction of the CSF pathway, or even some migration defects. Then in the Dandy-Walker malformation, there's cysts that are forming in the fourth ventricle, the posterior fossa of the fourth ventricle. Then you may also have atresia of the outlet of foramen. Then any other brain malformations can also be picked up. So here's the CT scan, and this is an axial CT scan that's showing the dilatation, marked dilatation of the lateral ventricles on both sides. As you can see, this dark area here, these are the lateral ventricles. Now, how do we manage hydrocephalus? So we should actually have an accurate diagnosis, identify any associated malformation, the clinical course, and the severity of the condition. So if hydrocephalus is actually arrested, spontaneously, surgical intervention may actually not even be needed. Medically, we do this when surgical intervention is not needed. So we can give a drug that's known as acetazolamide, 25 to 100 milligrams per kg per day, and this is meant to decrease the production of CSF. This is important in mild and slowly progressive hydrocephalus. We may sometimes give oral glycerol, which has a similar purpose to acetazolamide. And if the size of the head actually increases rapidly and is associated with progressive symptoms, like where vision and even life of the infant is endangered, then you may have to perform surgical intervention. So in congenital obstructive hydrocephalus, acquired hydrocephalus, periventricular ooze with hydrocephalus, we want to perform a ventricular atrial shunt, or preferably a ventricular peritoneal shunt, which is a much more common shunt, which is pretty much going to be draining the CSF directly into the circulation or into the peritoneal cavity, respectively. So a third ventriculotomy by endoscopic approach sometimes can be done in children with obstructive hydrocephalus. Then in the cases of infectious type, we want to treat the underlying infection because the acute hydrocephalus is self-limiting. So if patients have TB meningitis and progressive hydrocephalus, they may require a shunt if it is indeed obstructive. These are the different types of shunts that you may have: a ventricular peritoneal shunt, a ventricular lumbar shunt, a ventricular atrial shunt, a ventricular pleural shunt, ventricular spinal shunt, and a ventricular osseous shunt. And here's a picture of a child with a shunt that is exposed. This is a child with a subcutaneous shunt. As you can see, here is the shunt. And what are the complications? So you may have complications of ventricular peritoneal shunts, including shunt infection and shunt obstruction, but generally you can divide them into acute complications, infections, as well as slit ventricular syndrome, where small ventricles form within the shunt. You may also have long-term complications, like the child may outgrow the shunt may be blocked, it may be dislodged, and they may also develop shunt nephritis. And what's the differential diagnosis? It could be megaencephaly, where there is an increase in the volume of the brain parenchyma. There are no signs of increased intracranial pressure. The ventricles are neither large nor are they under any increased pressure that can help us say that this is hydrocephalus. We see this in Hurler syndrome, as well as in metachromatic leukodystrophy and Tay-Sachs disease. You may sometimes have a chronic subdural hematoma that can cause a large head, most commonly located in the parietal region, without prominent skull, veins, or even any sunset sign. Then other conditions that may present with a large head include familial macrocephaly, hydrocephalus, rickets, achondroplasia, which is dwarfism, and hemolytic anemia. What's the prognosis? This depends on the cause, the underlying cause. So patients with aqueduct stenosis usually have the best cognitive outcome. Patients with Chiari type 2 malformations may have a low normal intelligence and language disorders. Then patients with X-linked hydrocephalus usually have severe mental retardation. So here's our warm-up question, which is an OSCE station. A child presented as shown in the picture and the brain CT of this patient being followed up at Levi Mwanawasa General Hospital. What are the abnormalities shown in the CT image? So you have dilatation of both lateral ventricles. What is the most likely diagnosis? So this is hydrocephalus. Classify the causes and give one pathology in each. So congenital causes, it could be stenosis of the aqueduct, a Dandy-Walker malformation, and Arnold-Chiari type 2 malformation, or in acquired cause, which could be infectious like TB meningitis, chronic, and even pyogenic meningitis, or non-infectious like a posterior fossa tumor, that's a medulloblastoma, an astrocytoma, ependymoma, intracranial hemorrhage, ruptured aneurysm. Then what are the clinical features of this condition? So you have an increase in the head circumference, splitting of the sutures, sunset eyes, impaired level of consciousness, dilated scalp vessels, a crackpot sound on percussion of the head. I really hope you enjoyed this lecture on hydrocephalus and you learned quite a lot. If you did, consider subscribing to the channel, hit the bell notification icon to be receiving notifications of such videos every time I post. Tell a friend to tell a friend we are doing videos on the channel. To Zambia and beyond, my name is Dr. Moses Kazevu. Until next time, bye-bye.